Welcome, everybody, to the Longevity Lab. I'm your host, Juliette Root, and I'm doing a solo. Well, I guess it's not solo because I have a guest today, but you'll see why Mackie is stepping off to the side when I introduce my amazing guest today. Rachel Murray is a women's health nurse practitioner in obstetrics and gynecology, specializing in sexual medicine and menopause care. She currently is a part of a practice out of Charlotte, North Carolina, which offers services to patients for full scope sexual medicine and hormone replacement therapy needs. Not that Mackie didn't want to be here for this, but I was like, do you have lots of questions? He's like, I don't even know what questions to ask, this is good. I hope that maybe people who listen, can share this with their spouse or whomever is interested in this. And I know selfishly, I have a million questions for you about hormones, and it's like all the rage right now too, right?
It's very trendy. Menopausal care.
Why is it so trendy? That was actually one of my questions. Why is this so trendy right now?
I think it's trendy for exciting reasons. I think there are a lot of people making waves in this field, and I think women are finally getting the voice that they deserve. We go through a huge transition around the age of 50, sometimes earlier, sometimes a little bit later. And it drastically impacts quality of life for so many women. And that discussion has not been had. And what many people don't know is that in school, in medical school, whether you go to school to be a PA or a nurse practitioner, when you're learning how to be a provider, the education really isn't there for providers. And so that's a huge part of why so many women have gone to their providers or physicians and said, I need help, I'm having symptoms. And they're met with silence oftentimes because the education isn't there. And so now there's been a lot of post hoc analysis since the Women's Health Initiative, the WHI study came out in 2002, which I'm sure we'll talk more about. And that's where hormone replacement therapy became very hush-hush. Like before that, people were doing it and then everyone was scared of it. And now we have a lot of information and data to say, actually, this is not unsafe. And there are a lot of really incredible people out there that are getting the word out and increasing accessible care to women. The other thing that's happened is since COVID, virtual care has been increasing more and more, right? And menopause, hormone replacement therapy, non-hormonal symptoms and treatments for menopause, we can prescribe those. We don't necessarily need to see a patient physically in the office to do it. And so that's a really exciting for treating women who are going through these issues because we can increase that access to care and educate women so much more easily than we used to be able to.
Yeah, that makes a lot of sense. And I think that the reputation of hormone replacement therapy is something I'd like to talk about a little bit since we're touching on it, because there seems to be maybe outdated science and information that kind of gets just travels to where we are now. And even myself, like I have some kind of fears around HRT, but I'm not really educated on it, but just fears of like things that I've heard, like it could increase your risk of female cancers and things like that. So what do we know now that we didn't know then? What's getting cleared up around that?
Sure. So the Women's Health Initiative was a big study that was done to look at all-cause mortality for what all-cause issues that hormone replacement therapy might be able to help with. And it was stopped early because they found in that study an increased incidence of breast cancer and an increased incidence of blood clots. And so at that time, they took everyone out of HRT, almost everyone, and they said, nope, no one can be on HRT. No one can be on estrogen. It's bad for you. It causes blood clot. And so we've done a lot of studies since then, and analysis since then that reassesses what that study really showed. And what they found was that the data on breast cancer was found in women who mostly were over the age of 60. They were mostly on one formulation. So it was oral estrogen in addition to medroxyprogesterone acetate, which is a specific type of progesterone. The increased incidence of breast cancer is low, but if it happens, it's on that specific formulation. But we have multiple formulations that we can put women on. There was actually a decreased incidence of breast cancer found in women who were on estrogen only. So everyone became really scared of estrogen when really we're not totally sure that estrogen is the only culprit. At this point, we say in general, when you're on both estrogen and progesterone, there's about a 1 in 4,000 increased chance of breast cancer. So it's very low risk, but it does exist, right? And we want to make sure that we're educating patients about that. And then in terms of blood clot, again, its study was done on women mostly over the age of 60 who had additional comorbidities, right? So these are not all healthy women. They could have had high blood pressure. They could have had diabetes. other things that put you at risk for blood clot. And what we know is that one, the risk is very low. The oral formulations are a little bit higher risk for blood clots. So often we'll try to start women on transdermal options. And that's like a patch or a gel or a spray to sort of bypass that first pass effect that goes through the liver. We know that's what's associated with the clot, but it's very, very safe. And what we also know is that it can be helpful. So it can potentially prevent osteoporosis. It can potentially be beneficial for the heart, and it can help with cholesterol levels as well. So the discussion for 20 years or more, about 20 years was more about HRT is bad. It causes breast cancer and it causes blood clots, as opposed to, well, there's these really minimal risks, but also it can do these other really good things for the heart and for the bone, and it can increase longevity potentially. So let's really weigh this out. And then not to mention the quality of life issues that have happened for so many women, right? So when so many of us lose estrogen, we have the hot flashes, we have the night sweats, we have the issues with cognition, all kinds of things can happen, increased incidence of osteoporosis. And so replacing the estrogen is helping with the symptoms.
Yeah, I was going to ask you, that's really helpful to have that background information on. And it also sounds like, yeah, you have to take into account the person, the patient, right? When you're working with somebody, I'm sure you're looking at what are the comorbidities of this person, what might be the right dose for this person versus these like big studies where you're saying they were just looking at people over 60 who had all different types of health issues. They weren't all one and the same. So that makes a lot of sense. It's like that with all different pharmaceutical studies, right? It's like we have to look at who are we actually studying at the
Yeah.
end of the day. But I would love to just personally, I feel like I'm just dipping my own toe in the waters of learning about hormones because I'm 35 and many of my clients are in their 40s and their 50s and many are in the perimenopausal stage or they're where I'm at where they're sort of heading there and they really
Sure.
want to educate themselves and understand like, what do I need to care about? What are the hormones? What's happening in my body that I need to be aware of? So I was thinking we could do a little like, here's a 5-minute 101 from Rachel on
Yeah.
the hormones that we need to be thinking about and what are they responsible for and what's happening as we go towards perimenopause. And
So that is a really great question. And probably the number one thing we get asked in any OBGYN office and in my office is hormone testing, right? Everybody wants their hormones checked. And the first thing I tell every woman is like, I'm never going to tell you no. I will always draw your hormones. I'm very happy to draw them. Generally speaking, drawing hormones doesn't give us much information, right? And that's because if you're having regular periods, your hormones are doing what they need to do each month. They're going to fluctuate throughout the month. But at the end of the day, me drawing your hormones doesn't give me a ton of information around that. There is a time and a place on day 3 through 5 of the cycle that in certain situations, drawing hormones can be helpful. But if you're having regular periods and I draw your hormones during that time, they're very much likely probably going to be normal. So women can start to experience symptoms. And I think you and I talked briefly before, and I was talking about this. I'm going to repeat myself a little bit, but there's something called the straw classification stages of menopause. And it's a long classification system. I think it starts negative. It starts with like stage -3 and goes to stage +2. Might start with stage -5. But there's all these stages that look at a woman's bleeding patterns in addition to her symptoms, in addition to what her hormones are doing during that time. And during a lot of these stages, bleeding patterns are normal. So women might start to have some symptoms and have some slight shifts that I can't necessarily measure, but it doesn't necessarily change anything. And it's not even going to impact her fertility necessarily. Like it's just a shift. Right. And over time, slowly, as we move through the classification, eventually, right, fertility does start to shift and change. And that looks different for different women. It could be at 35, it could be at 42, it could be at 50. We just don't know. So menopause is considered one full year of no period. Perimenopause can be 10 years prior to that. So if you think the average age of menopause is age 51, so it can start around 41, depends on the person, could start for some women in their 30s, could start for some women in their 50s even. And later, bleeding patterns will start to change and they typically start to space out. Sometimes they can get a little bit wonky and be closer together, but generally speaking, they're going to space out. The symptoms that women may start to experience are the hot flashes, the night sweats, fullness, just kind of feeling like you left your keys in the room, but you can't remember which room you left them in. Some women experience weight gain, like around the central abdomen. That's the most common place that we see it. And that's because women have increase in visceral fat. That's just a little tricky to lose. Really random. Some women have burning tongue. That's a really
Interesting.
rare one that people can report. Joint pain is a common one. So often women will think that they have like arthritis when really that's one that's fixable with hormones. So the shift is really individualized for everyone. And it depends on how much it's affecting somebody as to whether or not we do something about it, right? For some women, we don't need to do anything. And at this time, there's not an indication as much as HRT can potentially be helpful for cardiovascular disease and helpful for osteoporosis. We're not saying every single woman should go on hormones, right? So it really depends on, is this affecting your quality of life? How are you feeling at this time? And if you can go through these phases and not feel anything, that's awesome. We don't need to do anything.
Yeah, I'm seeing this trend younger though. You're sharing that average age is somewhere around 50 for really going into full menopause. It can be different
Sure.
obviously for everyone. And then there's this 10-year perimenopause. So starting maybe in the early 40s that you're starting to just sense some changes. But I'm also seeing trends a lot in health and wellness online of once you turn 35, you're going
Sure.
towards perimenopause, and then you really have to think about your hormones all the time and pay attention to how you're feeling, and almost like this blaming everything on the hormones, which then I am starting to feel that a little bit too, like I'm having a bad day and I'm like, "Should I be blaming this on my hormones? Is this am I emotionally unstable
Sure.
because of that, or is it something else?" Like, how can we tell?
Well, and I'm here to validate that, right? Like we don't, that's the thing. Average age is 55, is 51. We don't know at 35, if you're going to potentially be menopausal at 45, which can happen, then you could start to experience those symptoms at this point. And like there's data to show that testosterone, for example, which is really great for libido and good for cognition, that's a hormone that women start to see a drop off at the age of 35 and then sort of bounces around a little bit in the 40s and then again in the late 40s. And this is very much speaking in generalities. But we do see those shifts. And that's what I mean by it's case by case, it's generalized for everyone. A really common one, so two of them. One is mood lability. Like I have a lot of patients they're like right before my period. I'm just in a terrible mood. And that's because that drop off of progesterone becomes more significant. And so women often, like if we just replace progesterone in that second half of the cycle, that can be really helpful. What is the other one that I wanted to say? More periods can become more painful. That's a big one too. Like women just start to have more painful periods. Sometimes periods are more heavy. And I don't necessarily have a hormonal reason that happens, right? Like I can't draw her hormones and say like, your estrogen is really high. That's why this is happening. Or your progesterone is low and that's why you're having pain. But we do see that. And often for those women, we'll offer birth control if they want to. That's a more nuanced conversation, but that is a really good way if women are open to it to prevent pregnancy because you can still get pregnant until you're menopausal, right? Technically. And also, if there are hormonal fluctuations going on for some women, it can help level them out, which I know some women, birth control is not great, but
Yeah, well, I think it's a very nuanced conversation with all of these medicines, right?
sure.
And there's a lot of fear around something like birth control where there's risk, but there
Yeah.
could also be reward, right? So it's like case by case, and I think really understanding what you're getting yourself into, which and educating yourself, as well as having a really amazing practitioner like yourself who can speak to this and educate versus just a 5-second conversation of, "Here, I think this is what you need," and then there's no real follow-up from
Yeah.
there, and I do see that a lot with people. It's just like, "Oh,
Yeah.
my doctor just told me take birth control and for this, for my acne or for my heavy bleeding," or whatever it is. It's like but there's no real follow-up or education around, well, there could be also risks related to that.
Well, and I loved working in general OBGYN for certain reasons, but one struggle I really had with general OBGYN is we as providers don't get much time, right? In general, it's very hard to find a place where you're going to be able to have more than 15 to 20 minutes with a patient. And so I think that's where things get missed, right? Because we know we have good data that birth control can help with a lot of things. It can help with pain. It helps prevent pregnancy. It can help with hot flashes, night sweats, all the things that I'm talking about with hormone replacement therapy. So that gets discussed, but like the fear around birth control or the patient who's been on 5 different birth controls and she didn't feel well on it and she knows her body well enough to know that she doesn't feel well on birth control. And that's not a good option for her. Like that doesn't necessarily always get discussed, right? Or just and speaking to like the information around it and really educating women on like, okay, these are what your options are. This is what we're working with. And we don't necessarily have all the tools in the toolbox, right? Like I wish that I could tell that I could have an answer for every hormonal shift and change that's going on and have a treatment that really speaks to my patient rather than just saying, okay, we can do A, B, and C. And we don't always have that, but I think giving information is so empowering. And that's kind of the missing link a lot of times.
So, are the three hormones that we're mostly talking about progesterone, estrogen, and testosterone when we're talking about hormone replacement therapy and what's changing over those years? Are those the three that we're looking at, or are there any? Is there anything else that you look at?
Well, follicle stimulating hormone is a big one. So, when women go into menopause, we're going to see a drop in estrogen, right? And that drop is going to go like this for a long time. And then progesterone also is going to drop, but it's also going like this. And especially in the second half of the month, it's really falling off. And then testosterone is for many women, it will start to decline in their mid 30s and then sort of drop progressively. But for some women, it kind of declines and it kind of go back up and then it kind of like declines again. And then for some women, they don't have an impact on testosterone at all.
What are these hormones doing? I think that if you asked me, Juliet, what are all those hormones doing? I could give you like the most basic answer and it probably wouldn't even be correct.
Probably would be correct. Well, estrogen is my favorite. Estrogen is amazing. So
You
estrogen,
need an estrogen tattoo or something.
that's right. I should do that. I've always been scared to get a tattoo, and I should get an estrogen tattoo when I do it.
Can't wait.
But so estrogen is going to help regulate us, right? So what estrogen does, very, very simple answer is it helps build up the lining of the uterus. And I'm just going to keep it that simple. But we also have estrogen receptors throughout our entire body. We have estrogen in tissues everywhere. So in the heart, in the brain, in the bones, in the uterus, in the breast, everywhere. And so that's why we see this drop off, like when we have hot flashes that has to do with temperature regulation, and that's usually associated with the brain. It can potentially prevent cardiovascular disease, right? And that's because we have the estrogen receptors in the breast or in the heart. So there's estrogen in the, oh my gosh, I'm so sorry. I have to say it, but like estrogen in the vagina, that's really, really important. We see vaginal dryness after menopause. It affects a lot of women. And that's because that tissue, those receptors get sucked up. So that's what estrogen's doing. It's really valuable. It's helping the lining of the uterus. Progesterone drops, and then that's when the lining of the uterus gets shed at the end of every month. That's sort of the purpose of progesterone. And progesterone is also really good in sort of aiding all the things that we're treating it for if we're doing hormone replacement therapy, right? So like helps with sleep, helps with mood for some women. It just depends on the person. Testosterone, libido. That's the big one. So, and again, like if that doesn't affect you, if that doesn't bother you, then we don't necessarily need to do anything about that, right? But if you're finding that you're having low libido, then we might talk about testosterone replacement.
Does testosterone also impact someone's ability to maintain like muscle mass or build muscle mass in that way?
Yes. Oh gosh, that's a good question. I feel that it does. And I feel that there are fitness people who can speak to this more than me can.
Yeah, this is something that's starting to, again, be very trendy in the fitness industry because there are different coaches and trainers and also exercise scientists that are coming out who want to work specifically with women's fitness around their cycle and training and eating specifically around the cycle.
Well,
And
the longevity thing, right? This is like
a little bit of a longevity
right?
thing, but I also think it's just also about more of a, like a biohacking your way into
Yeah.
feeling your best and having your optimal performance around different phases of your cycle. I know for me, like definitely I'm not the same every single day in my cycle as far as my energy goes and my strength goes. And I'm not going to get up my personal best run or lift on the first day of my period or something like
Yeah.
that. Right.
Okay.
So So it's kind of like speaking to maybe we should look at how to train in the best way to support the cycle. And that was something that was brought up around testosterone. And if testosterone is decreasing, it might be more challenging. Your strength might decrease or your muscle mass might be harder to build muscle, things like that. So
You bring up something important for me to look up. Testosterone, the only context that I know of that we're using evidence-based testosterone is for libido. And that has been really hard to come up. We don't have FDA approved testosterone in the United States for women, which is an issue. They tried to do a study on this and get FDA approval, and I forget why it was taken away. I think it was around and then they took it away.
but they have it for guys. They have
Oh,
testosterone.
yes, we have it for men.
Yeah, because TRT is like all the rage with
Yes,
guys. Yeah.
that's a problem. Like the lack of support that we have for women in research and this it's in this field is a huge problem. But so we use 1/10 the male dose that we do, or use 1/10 the male dose for women, right? When we're doing testosterone. I don't know evidence behind muscle building and optimal performance, but it may be out there in the athletic field, and I'm just not aware of it.
Sure, sure. Yeah. It's something I'm interested in, especially as I have women come to me with they have increased visceral fat as well as subcutaneous fat as they're going towards menopause. And they're saying the workouts that I used to do are no longer working anymore. So my body's not responding in the same way that it once did, where I was able to like lose body fat and build muscle mass. So something I'm really interested in around what's happening hormonally that could be playing a
Such a
role
great
in that.
The only thing I can tell you about that I'm looking more into now what we can do for women who are struggling with weight gain at this time. Because really what we tell women is like, that's one thing that we have so much information on hot flashes, or we have information on low libido. But as far as treating the weight gain and the central weight gain, a lot of times what I end up doing is just sending women to a nutritionist, which there are ways, and you're probably familiar with them. Like there are ways to sort of get estrogen to activate in your body with dietary changes as well. So you probably teach your people about this, but like flax seeds, legumes, nuts, those are all things that can potentially be helpful. What was I going to say about this though? I just totally lost my train of
Well,
thought.
I think this is one of the biggest fears around this for women. It's like, yeah, obviously hot flashes, feeling like you're in a bunch of burning flames out of nowhere sucks. But I think women feel so out of control when all of a sudden they have this midsection weight gain and their body just is unrecognizable.
Yeah.
And the exercise or the way that they ate, nothing changed in that regard. It's just all of a sudden because of their hormones changing that they have this weight gain, and I think it's like feels really powerless for a lot of women, and I think do you find that that is a lot of why women will kind of like how they get to you too, is that yeah.
Yeah, and it's hard because we want to help, and the data is really sparse in terms of what we do and how we can help, right? But that's what I was going to say is if a woman is open to doing hormone replacement therapy, which if we're going to do this, we still want to be evidence based about it, right? Like I'm not going to tell a woman to do HRT to lose weight. If she's having hot flashes, it could be appropriate to do HRT for her hot flashes, and if she does estrogen, that could help redistribute some of that tissue, right? But it just depends. There was also a new study that came out like last week about some of the GLP-1 and doing that with women who did it with hormone replacement therapy with estrogen had increased results.
Interesting. And for those listening, I just had a recent podcast, not really on exactly what GLP-1 drugs are doing, just on the interest and that people have in them and why this is such a hot topic right now and why it's triggering so many people talking
Sure,
about everybody on drugs like Ozempic, Mounjaro,
sure.
etc.
Yeah.
That is really interesting. I think yeah, because there's also issues with blood sugar, like glucose regulation, things like that that happen during this time as well. Are you're seeing a
Yeah.
correlation there with these with the decrease in these hormones and then blood
Yeah.
sugar issues
So
happening?
Yeah, so it's not again, it's not a reason to put someone on HRT, but this is one of the benefits that we can see with the replacement, right? But that's again, like the shift is there, but it's also contingent on what does my patient want, right? And does she want to go on hormone? Because that is such a tool that we have. Or for us, there are a lot like when we look at the symptoms that women experience during this time, most of the data that we have is going to be on treating hot flashes, and for that, we have the hormones. And then we have non-hormonal treatments that we can use. But aside from that, like there's not, in terms of like treating diabetes, or treating A1C, right? So looking at your glucose over the course of 3 months, if that's starting to elevate and going toward the pre-diabetic range, I don't have like an additional tool in the toolbox that I can use other than saying just eating less sugar and
Yeah,
all of my
it
very
sounds like your practice and working with whether it's a dietitian or nutritionist or a strength and conditioning coach, they go really like hand in hand because I was going to ask you, what are some of the most impactful lifestyle interventions that you can see do support hormonal health for women?
Well, that was why I sent you a thing last week on that, because such a big piece of it really is staying active. We do know that with decrease in estrogen, we have loss of bone density, right? And so over time, women are at higher risk for fractures and falls, and that's a big concern. And we know that with activity and exercise and building up that density, that can really have an impact. So that's like number one. Diet is also going to be really important, right? And we do see, you probably see as well, some women have a really good regimen for themselves and have a really good program. And then some women are, probably one of them. Like I'm just kind of making things work day to day. My carbohydrate and sugar intake is not what I wish it was, right? And so over time, that might start to impact me more, right, than it has in the past. And so just really working on like, okay, let's decrease our sugars, let's decrease our carbs, let's increase our proteins, all of the things that we know how to do. Diet and exercise really does go hand in hand with this in terms of just changing the game and how you feel. We don't have data at this point that diet and exercise actually impact. Like if you start having hot flashes, I can't tell you that by dieting that, or I don't like to say that word. I can't tell you that by making changes to the choices and what you're eating, that's going to fix the hot flashes. What we do know is that if BMI is higher, which I think you don't like BMI, or didn't I hear this recently? Like we're trying to do away with BMI.
Well, BMI, it's just it's case by case, right? Like I'm not against BMI because I do think that if someone is 5'4", a female, and is 300 pounds, that's a very unhealthy BMI. But if they're maybe a little edging towards the high end of overweight in the BMI scale, but they're really muscular and they have low body fat, then that's not an instance where we would say, like, you have to lose weight to be healthier because that person is probably a lot healthier than the average person because they have a lot of muscle mass and their body fat is low healthy.
Yeah. So generally speaking, what we know, and this is speaking in terms of obesity, so same idea, but if we can decrease some of that body fat, we do see a decrease in the hot flashes and some of the symptoms.
Yeah,
So
there's an interesting exercise physiologist. Her name's Dr. Stacy Sims that a lot of people in like my fitness world
sure.
love her. She has a book called Roar. She was just on, and I think in one other book, I can't remember, but one is about menopause specifically. And
Write her down.
looking at, yeah, Dr. Stacy Sims. She was just on Ali Shapiro, who I just had on the
Yep.
podcast, guys. She just did an episode with Dr. Stacy Sims. And it's awesome the work and research that they're doing. It's out of New Zealand, so I don't know how that research comes to the United States because that's all separate research. I'm sure it's not a whole nother country, right? But
Sure.
they're looking at how certain types of exercise can kind of play a role in almost mimicking the hormones that we no longer have a lot of,
Yep.
like estrogen and testosterone, and heavy strength training in women. And that again is relative to like what's heavy for you.
Sure.
So, but going to your 80-90% effort of strength where you're really getting a central nervous system response is showing good results in the symptoms with women, along with a higher protein diet. And of course, managing blood sugar, like we're talking about. So, and you had mentioned to me you're like, you're probably not going to experience, who knows, I hope, as many crazy symptoms if I kept my lifestyle up with the amount of like exercise that I'm doing.
Yeah, I do think that there's something to be said for that. And this is why, like I mentioned to you when we first talked, I wish we could just put all of us into one office, right? Because
Yes.
it all putting all of this together is so important, right? And I wish people didn't have to come to me and then I said, okay, go see this nutritionist, or like go walk on your own, which is really hard for some people to get motivated enough to do that, right? Like if we
Sure.
could create a full system so that people have all the tools, because truly so many people don't want the additional medicine, and then some people come to you and they do, or they want the adjuncts. And so we all need,
Yeah. I think seems to me to be a theme in almost everything when it comes to health is that metabolic health is so important. That is like what that if that's not there, then you were just kind of band-aiding things and like medicines can help and all that. But if we're not addressing the underlying metabolic health, then
Yeah.
we're missing a big piece of this.
Yeah. And I think what I would like to see is more and more research come out around this, right? Because all we have right now when we're thinking about just like weight gain specifically is okay, well, we don't really know that hormones can do much and we don't have anything else. All we can do is put you on these medications. Like from a medical perspective, right? We're not
Sure.
really coming full circle with all of that. And so I would like to see things go in that direction so that we're giving people all of the options.
Yeah, the fact that there's not a ton of research on this until more recently just
Yeah.
shows we have a long way to go, and that there was research that was happening that got stopped for so many years
Yeah.
is just mind-boggling to me. Like, women are so left out. It's so sad.
Yeah.
Like, and
Yeah.
also the same thing with diet studies when there's these big meta-analyses of diets or different types of exercise. Oftentimes you look and see it's like these were all guys.
Yeah.
Women weren't even in these studies. And
Well,
then women are like, I'm going to do this fast or I'm going to do this thing. And it's like the data wasn't even on you.
yeah, that's a huge part of sexual medicine as well. And we often have to, like, if you look at testosterone, we have we have better information now, but it's also figuring out things from studies on men because that's
Just a sidebar. So I was in LA this fall. And depending on what city you're in, there's just, like, different vibes. Like,
yeah.
Boulder has a very, like, rock climbing and endurance athlete, and we're, like, named the worst dressed city all the time. Like, I think Birkenstocks and all the way. You always look like there's, like we go out to a nice restaurant and everybody is in, like, Patagonia and, like, they look like they just got off a hike. Nobody tries. But it's
Right.
great. It's very freeing for me because 'cause I'm,
So
like
good.
I'm just
Yes.
wearing my pajamas all the time.
That's
But as we know, like, LA, very different vibe. Hollywood is
yeah.
there and a lot more, like, keeping up with appearances, and I was at a dinner table with a bunch of people in the fitness industry, and it was amazing. All the guys are on TRT, and they're young men. They're late 20s, 30s, just trying to get absolutely shredded and whatever they think is amazing. But I was like, "This is crazy how many young guys are on testosterone replacement therapy." From what I know is, like, once you go on it, your body stops creating it, so that's gonna be, like, a lifelong thing for these guys that they have to take it.
Yeah, that's crazy.
I know what's going on here.
That I have not seen anything. Where are they getting it from?
I
Is this
don't
like
know.
evidence-based?
What'd you say?
Is it like evidence-based or is this like testosterone? Because in the in for women, a huge issue now is testosterone pellets.
Yes.
So, and a lot of women are getting pellets inserted, which there's when we look at, we just don't have the safety data behind it. So it's a big concern because women are just going wherever to get it done as opposed to doing much smaller doses in ways that we know are really safe.
That's really interesting. So I know one person who did that as a woman who did the pellet, and I remember it being challenging because once the pellet went in, it wasn't exactly the dose that was what she had expected. She knew going in that it was maybe gonna be not exact, and she was aware, like, it's a little bit of an experimentation, like, seeing how my
Yeah.
body's gonna react to this, but once it's in for months, right? Like, it's releasing is it, like, time releasing or
Well,
something?
that's it. Yeah. So the issue, that's one of the issues is that once it's in and you can't take it out. And it will come down. It will come down over a couple months. But the big concern, like if you look at the testosterone levels for women, this is also a very, very general statement, but around 55. So some of these women who get, I've seen testosterone at over 300, but you can see it higher. And that we just don't know anything about it. Like we don't know about the risks and what it's doing. And so that's the big concern.
Yeah. I've always been into holistic medicine and I've
Yeah.
gone to different functional medicine doctors and naturopaths throughout the years. And there's so much testing that goes on in a lot of those practices. And like hearing you share that, hormones are something that we really can't have a great grasp on by just like testing through your blood one time where your levels are, or even a lot of women will come up to me saying that they took something called the Dutch test,
Yeah.
which I took as well, which you take it over the course of a period of time. I think it's like a few days, and you have to time it where it's a certain point in your cycle to maybe give you a better interpretation of what's happening. Just in my own experience, where that left me was feeling very powerless because it showed some things that were that were low range, and maybe not were abnormal for my age. I think I shared with you that that left
No.
me feeling like, well, what am I supposed to do with this? Because, like, I'm not in menopause, I'm getting a regular period, but I have noticed things at 35 that are different than when I was 28.
And you want answers for those things. Yeah, the dust tip, I actually thought about you a few days later because I was listening to, I think I had like a book on audio. I'm reading a really amazing book. Anybody who reads books, Lisa Mosconi, The Menopause Brain is off.
Oh,
But
I
it's,
just heard about this book. I'm gonna write that down,
yes,
The
it's
Menopause Brain. Okay.
Menopause Brain. So it's just a really incredible discussion around menopause and the impact that it has on the brain, and also just changing the conversation around menopause and very empowering for women. But she talked, I think it was her book that I was listening to that was talking about the Dutch test. And we just don't have data behind it. Like, it's fine if you want to go get it done, but I think it's expensive. I don't know.
Probably a few $100s at least.
More like I know there's just the accuracy isn't necessarily there. And then also, yes, what are we doing? And then I think, can I share what you told me?
Yeah, yeah, no, absolutely. I'm an open book.
Well, you were like, oh yeah, they told me to take DHEA or something like that. And so what I had said is DHEA is not something that's also another hormone that don't necessarily have evidence to show that it's going to do anything. Right. So a big part of addressing these hormonal concerns now as well is really making sure that we're getting accurate information out to women. And a big concern is that there's so many places that women can get their information, right? And I'm the last part, like I think it's really important to hear all different perspectives. And I think that there are really great providers out there. Dr. Sarah Gottfried is someone who I really like. She posts great information on Instagram. She's written multiple books and she's talked about Dutch testing. And so I think there's a perspective for it, and that's fine. But in general, when you look at a number of these places that people are getting care, it can be problematic. And a huge thing that we sort of grapple with in our world is compounding pharmacies. So that's a lot of women will say, well, I want to go to a compounding pharmacy because I want to get hormones that are identical to the hormones in my body. But all of these hormones, whether you get hormones from CVS or you get hormones in a compounding pharmacy, they're all being made in a lab. They are identical to your body. They're not being made any differently, right?
Mhm.
But what we also know about compounding pharmacies is that they're not regulated in the same way, and they're
What
not
is a
studied.
compounding pharmacy? Is that where, like, supplements you're talking about?
They can put so I can give someone estrogen and she can go to CVS and get estrogen, or I can send it to a compounding pharmacy, which I will do in certain situations, and they can formulate it in a specific way.
Okay.
So, for example, if I said, maybe I want a patient to have, this is not a real example, but there's multiple types of estrogen. So I, percent of the time, will give women Divigel, which is, I will always give estrogen in the form of a pill or a gel that they're getting at a pharmacy. But let's just say I wanted to do estriol, which is a weaker estrogen in addition to estradiol, which I can't really think of an example where I want to do that. But in theory, I want to do that. Then I'll send it to a compounding pharmacy and they can put in like 25% estriol,
Okay.
25% estrogen, or 75% estradiol, and kind of make it the way that I want to. The concern around this is that there are tons of them. Some are regulated more than others. None of them are regulated in the ways that we would like for them to be. And we don't necessarily know how much hormone or how much medication anyone's getting.
Yeah, this is an issue in all supplements going on right now. When you
Yes.
test, I would just met this woman who owns a medicinal mushroom company, and she was sharing with me that they did like a sample of like 50 different companies that are offering medicinal mushrooms. And they looked at them and they didn't even have any mushrooms in them. Like they were using not the fruiting body, they were using the stem. So
Sure.
in all of these industries, supplements, or even I don't want to say in pharmaceuticals because that's way more regulated. If something's FDA approved, that
Sure.
you're getting, hopefully you're getting the right dose.
Sure.
But there's also, I think, a lot of people going towards the supplement route if they hear that they can take something that's going to help them with their estrogen or their testosterone or their progesterone that isn't
Yes. Yes.
actual HRT, but it seems more natural.
Yes.
And then they're
Yes.
going that route. But like, what are you actually putting in? What's in there? What is it, a reputable source? Where are you getting it from? It is really crazy out there.
It is very, very problematic. And I think there's a time and a place. Like there's certain people who can't tolerate hormones that are FDA approved, and we need to
Sure.
go, or maybe they have an allergy or all of all of those things. And if someone comes to me and she's really, really wants to stay on her compounded hormones, then I'll have that conversation with her. And I want her to feel empowered to make her own decisions. It's her body, right? At the end of the day. I think again, it comes down to just education and making sure that people have the information. But yes, and we will. There are some supplements over the counter that we can do that are basically doing the same thing. They're activating estrogen, various estrogen receptors in the body, and so that's great. But the regulation isn't there, so we just
Yeah.
have to be cautious about what we're telling people, right? Because we don't know.
Yeah. I think that one of my biggest fears with just messing with my hormones in any way, shape, or form is they are so responsible for so many things and how I feel, right?
Yeah.
Like especially how my brain is is functioning.
Yeah.
So
Yeah.
like the cognition aspect of this like really freaks me out. And I had one stint with birth control when I was younger and it's whatever that version of it scared me off so bad that I never even
Yeah.
wanted to try it again. So I think that there's like trauma too with some of these things with women. They're like really scared. I'm really
Well,
scared. Like if I get to the point where I have to make these decisions around if I'm going to try HRT or something, my only experience with any kind of hormones was from that time period and really left a scar for me.
Well, and it's disempowering. This is the problem, and I run into this all the time. And what happens is too, women feel disempowered and like they don't have a voice. And that's not to say that everyone in the medical field is that way at all. There are many amazing, amazing providers, but it is a big problem. And it's part of the reason, for a number of reasons, I was drawn to sexual medicine and menopause. But a big part of it was that providers I find who have chosen to go into this field really care about educating women and giving them a voice and helping them to understand why things are the way they are. Birth control pills specifically, again, we have estrogen receptors, progesterone receptors all over our body. And so you and I could both take the same birth control and react completely differently. You could take a billion other formulations and do terribly on all of them or do great. We just don't know. But without giving you that information when you're younger, and then compounded with the fact that, like, in order to get to the doctor, you have to make an appointment, and it feels very inaccessible for so many women to just talk to their provider and have access to their provider. They have to go to a big building, which, like, I don't know, the parking lots at medical complexes stress a lot of people. Like, I wish that these things that were easier for women to get to. And that's part of, I think, social media right now. I don't love it. I've heard you talk about how in some ways you don't love it all the time, right? There are
Well,
negatives.
this because again, like where's the information coming from? Is this like accurate information? Even
Sure.
when people are pointing to studies, sometimes there's cherry picking the data and it's like really hard when you're just kind of scrolling through. And also, I think we have confirmation bias a lot where we want something to be true for us. And so
Sure.
we like latch on to things. I know I do this where I'm like, that sounds really good. And that fits my story of what I want to be true.
Yeah.
But what if that's really not true and
Not the
it's not
best
good for
thing.
me? Yeah.
Not the best thing. Yeah. This is why, Julian, we all need to be in the same place and we can just give comprehensive care and we can have consults with our clients and our patients. And then we will all be able to give so much better
No,
care.
I'm with you. I think it takes a team, and I saw this with my mom. She passed away last year, and it was insane to watch
Yeah.
how nobody communicated.
Yeah.
Oncology didn't communicate with radiology, didn't communicate with primary care. And then I was trying to be this liaison of like, you need to talk to this person, and then you need to talk to this person. And I do hope for a better future that that does change. And I know that I do know that healthcare is revolutionizing and changing. It's just never like gonna fast enough, right? But it
Well,
is changing. Like, look at what you're doing. Like, look at your practice right now for sexual medicine. Like, that's not something that existed before.
sure.
Amazing.
Yeah. No, I think there are a lot of big strides being made. And I do just want to say I followed you for a long time. So I saw the post about your mom and I'm so sorry for all of that. And I'm even more sorry to hear I work in the medical field and it can be hard for me to navigate. So like
Sure.
to hear that you went through that as, with a cancer situation is just heartbreaking. And unfortunately it's the reality, right? And you want to speak about menopause, like so many of these women who go through cancer actually find themselves in menopause for various reasons because of medications they may be on or chemotherapy and all of that. And it can just be really difficult to navigate. But yeah, I think that things are changing. I think it's really exciting that there are so many people who are passionate, you included, like who really want to get accurate information out there to people and empower people to make decisions that are best for their body. We have a long way to go, but
Yeah, absolutely. It's interesting that you touched on that with I have had some clients post-cancer come to me for support with strength and
yeah,
conditioning and
yeah,
nutrition
great.
and sharing with me though that they are in early menopause and they're
Yeah,
navigating that and the challenge of again weight gain
sure.
and
Yeah,
feeling like they are at a loss
yeah,
because doesn't seem calorie restriction doesn't seem to be doing the trick,
yeah.
doing more exercise, right? This whole idea of eat less and move more is not always applicable. And I will fight people on this because there are so many influencers and registered dietitians, mostly men, I will say this, mostly men,
Yeah.
who are really like, it's you're just overeating. You really are. I have spent intimate time with women who that is not the problem. That's not
Yeah.
what's happening. Like
Yeah.
nutritionally, they a lot of times women actually need to be eating more than they're
Yeah.
eating. Their bodies in a low they have low energy availability. They need to build their body's energy back up, not keep depleting it with eating less and less, hoping that their body's going to let go of extra fat. It drives me
Um,
nuts. It makes me so sad because it's like, again, this disempowering situation that happens to a lot of women, especially going into menopause.
so do you ever work with thyroid patients
I
in the
have I have worked with like Hashimoto's and different thyroid issues
the
over the years.
hardest? Yeah. So that's one of the hardest ones is women who have the struggles with Hashimoto's but also like are on the medications and still really struggling with diet. Cancer though, the cancer treatments, the chemotherapy and the medications that prevent women prevent cancer from returning, they take our estrogen levels down to basically zero. So
Yep.
all of the things that we see in menopause with hot flashes, forgetfulness, pain with sex is a huge one. Women go through all of those things. Women who have mutations that make them more susceptible to certain types of cancers, so BRCA carriers, they might decide to lose both ovaries before the age of 40 for various reasons, and they're going to have no estrogen. And that's all important. Like these treatments are very important. But the problem is that not all of these patients are getting educated about, okay, this is what's going to happen. This is what your quality of life is going to look like.
Mhm.
And it's a big issue because some women, the conversation for some women is going to be about quality of life. Right. And I want to feel better. Like I would rather take this risk and feel better than feel terrible. Or at least I would like to be given the information first. Of like,
Which is so great. Like for sometimes it's just good to know, oh, this is a normal thing. And that just like relieves some of the tension around something versus wondering like, am I okay? Is this right? Is this wrong to have this going on? Sometimes just knowing like, oh, this is normal. What's happening in my body is the thing, the permission that we need to just feel better
better.
in
Yeah.
general
I
without
mean,
even
I can say,
necessarily having to do something about it.
yeah, like we have so many women come in and they've had pain for years with intimacy. And then they just say to me, oh, I just thought this was my life now. And it doesn't have to be, right? There are things that we can do to really help. And hot flushes too. Like I just had a patient come in the other day who is going through chemotherapy and having significant hot flashes. And she actually chose not to do medications. But there are medications that she can do to not have those hot flashes that are not hormonal and would still be safe in her situation. So it's just,
I know we don't have that much time left, but I would love to touch on 2 things. The low libido and when you start to see that happen in women and the cause of that and how to support low libido and how to know, like, is it that you've just been with your partner for 20 years and you're just not that into each other anymore? Or
sure.
is this
Is there something
hormonal,
else
right?
going on?
'Cause I think that's something a lot of women question, like, is this me or is this the situation, right? Is it my body? And then you mentioned helping women with the inability to orgasm. So I'd love to hear just a little bit on that. But first on the libido topic.
Yeah. So low libido is there are very general terms. There are three big reasons for low libido. One is certain medications that women are on. The other is hormones. And most commonly, I'm talking about testosterone, but we do see a drop in libido from lack of estrogen. Testosterone is typically testosterone replacement. If we're going to do hormones, that's usually what's going to help with the libido. But we don't really have information to show that replacing the estrogen can help. And in some cases, I will offer that. And then the third is life and stress, which is real. So there have been studies done on women who have had sexual desire disorder. And am I frozen?
You're good. You're not
Okay.
frozen.
In order to get that diagnosis, you have to have lack of desire that's been going on for 6 months. There's nothing else that we can point to say like, okay, this is what the problem is.
Can I
Um,
touch on that and ask you a question about lack of desire?
yeah.
Because I know I'm speaking on the behalf of a lot of women here with that. Is it lack of desire to have sex with your partner as well as like pleasuring yourself? Or is it lack of desire completely like you're not into pleasuring yourself and you're not into having sexual encounters with another person?
That's a good question. So technically, HSDD, hypoactive sexual desire disorder, is lack of desire, period. Right.
Okay.
So if there's an issue, generally speaking, with lack of desire with your partner, but not with yourself, then we want to think about, okay, is there something going on? Right. Is there something that's sort of breaking down here? But there have been studies done on women who have HSDD compared to those who don't. And all of these women have been shown erotica. And what they found was there's actually decreased blood flow to the prefrontal cortex of the brain in women who have HSDD. So I think that's really important to say because that shows us, okay, this is not something that you've just created and that's going to get fixed with a glass of wine, right? Like this is a real issue that women can go through. But it's also saying, yes, stress can be the factor. And I think what a lot of women end up hearing and what a lot of providers also don't know is that like stress, a lot of women, when they hear like, oh, you're just stressed, I think it's delivered inappropriately, right?
Well, it's
Because
also like, yeah, I have 3 kids, a
yeah,
full-time job. I gotta pay my bills. What yeah, how the fuck do you think I'm supposed to not be stressed?
yes. And that, but also like that is a very real, that can have a very real impact on her desire that is also affecting how her neurotransmitters are being released, communicators in the brain, how her hormones are being released. All of that impacts it. And the other thing that I talk to women about is it has to do with like how we're raised. How are we raised in our family to talk about sex? How have our sexual experiences been? Do we have any trauma from our past? Context is really important. So all of these things weigh into it. And I did touch on hormones for treatments, but we also have non-hormonal treatments for low libido. So those treatments, the other thing with desire is we have reasons for low desire. The treatments that we use in general are working on communicators in the brain. There's one that works on melanocortin receptors in the body. And all that to say, it's not necessarily treating like the cause, right? That one specifically I'm talking about by Lisi, which is a medicine that you can inject into your thigh and it makes you want sex 45 minutes later.
Oh, wow.
But it's a medication that can work, right? And so, yeah, we want to talk to women. We take what we call a biopsychosocial approach. We really look at the full picture. Everything really impacts it. This is not a medical thing that I'm looking at only through that lens. I'm looking at your relationship, your history, what's going on at home, your eating, your exercise, all of that, and really formulating a plan based on
Yeah, it sounds like it
everything.
is a very complex and case by case situation with something like this. I love that you guys take a more biopsycho analysis of people because that's exactly what I was thinking. It's like could be trauma, right? Like could be how you were brought up to think about sex and shame around sex and all of that, right? And I think also there's different honeymoon phases people can go through with their partners where some of that stuff doesn't even come up until you get really vulnerable with somebody and you let your walls down and then you can actually become less sexual over time when really it should be the time when you're feeling the most comfortable with somebody, but there's so many like complexities with this and in our brains. So that's really wow. Just thinking about the prefrontal cortex and that's what they're looking at with that is really, really crazy. Is
Yeah.
that similar then, I'm sure, with the inability to orgasm too? Or are you seeing that more from an actual physiological standpoint?
So it really depends. A lot of times that's hormonal. There are changes to the vulva and the clitoris and the vagina that can happen for a lot of women. And birth control pills. So my favorite facts about sexual medicine is that birth control pills, 30% of the time, it can actually change the architecture in that area and change the way that the clitoral hood is covering the clitoris. The hood is a little skin, like keep the skin that's over the clitoris, and that can decrease sensation for women. It's another situation where we're sucking up those hormone receptors, the estrogen and testosterone receptors in that area, and it impacts women's ability to be able to climax, and it can also affect libido as well. So hormone, but orgasm is interesting. There could be issues with the spine. there could be issues. Brain is one of them. We look at medications that women are on because certain medications can definitely have an impact. And then we need to think about depression is a great example, right? Selective serotonin reuptake inhibitors can affect ability to orgasm, but I also don't want my patient to be really depressed if that's working to treat the depression, because that also can affect the ability to orgasm. So we have to look at it all and think about, okay, what are the changes that we want to make and how can we sort of maximize and make things good without changing too many things on the other side. I'm a huge proponent for sex therapy when looking at libido or orgasm. So there are sex therapists and sex coaches out there who work with women on talking about sexuality and like really evaluating what does that mean to them and how do they want to be intimate? And I think these are things that like we are not socialized to talk about. These are things that we're not learning about from a really young age. We don't know how to ask ourselves these questions because we don't talk to each other about them. And so I think that's a really great way to sort of like tap into things if a woman is comfortable talking to someone else about it.
Well, also, I was just reading statistics around, I believe it was Gen Z and how their desire to be sexual has decreased. Just in general, I don't even think it's just Gen Z. I think it's society in general is having
Interesting.
sex a lot less and not having as much desire. I think this is multifactorial, but I think the stress of like being constantly inundated with technology and
Yeah.
everything,
That is.
and we're getting this like dopamine we're getting these dopamine rushes all the
Yeah.
time with being on our phones, that we're almost stimulating something that we may have gotten through the pleasure of sex before or any
That
kind
makes a
of
lot of sense to me.
intimacy.
Yeah,
Yeah.
that makes a lot of I mean, it's very much a part of all of this. So, but I could definitely see that having an impact.
Crazy. I'm like, what are we doing to ourselves, people? Like just like imagining this dystopian future where we're all like killing ourselves off and
So,
our species is basically gone unless you live primal, right? Like the version of indigenous will be just people who don't have like an iPhone.
what
And
is the thing? What is the thing where you like they call it like phone snubbing, where you're like sitting with your partner and you're both in bed at night, you're sitting on your phone. I don't know. Subbing?
yeah. Yeah,
I
that's
don't
me and
know.
Mac. I mean, that's me and Mackie.
Yeah.
And we are so aware of it. We're just like, this is unhealthy. And yet there's such an addictive quality to what's happening. And it's feeding something in the brain and it's giving you those dopamine rushes. And it's like, well, I'm not going to get those hits of dopamine and I'm not going to get the novelty just from talking to you, which is
Yeah.
sad. But
Yeah.
that's really what is happening. We have a guest coming on, I think it's next week, who wrote a book called Open, and this is exactly what his book is all about,
Oh, that's
is
awesome.
how to be mindful and in a digital age where our attention is completely taken away and how to get back to that more healthy place and with our brain and our body because it's affecting us so much. But I think sexual health, it's there's so many things with it, but I think that is a big part of it, the stress too that we have with being on devices all the time.
No, that's a very, very smart thing to say, and it's very true. And so much of sexual health, a lot of it is medical, but there's also a huge piece of it that's just about, okay, let's like take a step back, let's reevaluate. Like, what do these things mean to us that we've never really thought about? So one thing that I'll recommend to patients almost every day is something called sensate focus. So this is getting naked with your partner in bed, touching each other in different areas of the body and not touching the genitals, but touching anywhere else and noting temperature and noting sensation. And it's evidence based and it's been shown to increase connection and decrease anxiety around intimacy. But doing things like this to really like be in the moment, be mindfulness, things that so many of us don't think about doing, really be effective for people.
Yeah, because 'cause we're just kinda disconnecting ourselves, right? Like, and then the longer that goes on, the more time that occurs, the less your partner anymore, the less you feel
Yeah.
connected to them. There's so much in there, Rachel, and thank you for coming on and sharing all of this.
It's so
I'm just
fun.
really trying to learn more, and I wanna learn evidence-based information around this so that I can best support my clients because that's so many of the women that I work with are in perimenopause and going into menopause, and I feel like I have a lot to learn still as a trainer and a health coach on how to at least refer them to people or give them evidence-based information. So
Yeah.
this was like a really good conversation for me because I also want to like prepare myself too. I think I'm someone who likes to prepare for the future. That's my
Yeah.
anxiety brain. I'm like,
Well, such good care of your body for so long. And I think the biggest, like when you speak about the weight piece of it, that is such a huge thing for women, especially women who have like known their body in a certain way and known their body in a really close way for so long. It can have a huge impact. And here's the thing that I'm going to say about evidence. And I think you first through a lot of this as well. But evidence is so important and it's also really hard, right? Because we
mm,
want women to feel good. And so we really want to think about like, okay, what is the full picture here? What does this woman want? What is she saying to me? So, like, I had a conversation with someone earlier today who said to me, I'm not doing as well on testosterone. Or no, that was what it was. It was weight gain on testosterone. So, testosterone is helping with one thing, but it was also causing weight gain. And so I propose, look, we don't have evidence to show that estrogen is necessarily going to fix that in the wide studies that we've done. But I do know that lack of estrogen can cause decrease in libido. And so that's something that I presented to her as like, look, this is something that we can try. We don't necessarily have the information, but it's there for you if you want to try it. And so I think just really being open to these concepts and really giving women options in a way that really speaks to them is important as long as we're giving the full picture and all the information.
I want to add something to this conversation before we wrap up about the weight gain and that being so the fear, but then not acknowledging that some of these drugs can make you feel amazing in other ways. So while someone might gain a little bit of weight on testosterone, they could have an increase in their mood where they have a more stable mood. Or this is from my understanding, and also a client that I worked with that went through this. Like, okay, I
So,
did gain weight, but man, I feel so much better. She's really sharing that with me, like,
yeah,
so I need to evaluate, like, maybe it's okay that I gained 5 pounds but, like, my day-to-day is so much better. My
yeah,
cognition,
yeah,
my mood, my sleep is better, so all those other things improved, but she had a little bit of weight gain.
yeah,
I know that's really hard because there's so much emphasis on looking a certain way in our culture. Also, we have to look at health a little bit more holistically, that it's okay to like have a little bit of extra fat. Obviously, if that's not going to be to the point where you're putting yourself at risk for other things.
yeah. No, it is really important in terms of really looking at like, okay, what are our goals, right? And what's realistic and where do we want to go? And I'll often talk to people in terms of like percentages. What percentage is your libido better? What percentage are your orgasms better? So that we can, what percentage are your hot flashes better? So that we can really think about like, what is our next step,
Yeah.
right?
Yeah, I love that approach. Well, thank you. Where can people find you? I hope that you're not to say get on social media and give some information, girl, but I but I do love that you're starting to share more. So where can people find you?
Oh, you're so awesome. Okay, so I'm on social media. It's Rachel Murray, WHNP, and I'm on NAM. So if you want to find a good menopause provider, you can go to North American Menopause Society online, and they have providers listed on there. And these are people who practice evidence-based medicine, and that doesn't necessarily mean giving hormones. It means practicing evidence-based medicine. So that includes supplements as well that we might do and having these well-rounded conversations. I practice in Charlotte. So to actually see me, you have to be in the state of North Carolina, but we do virtual visits at my practice. So I am at Atrium Health and I think just the website, right? If you
Yeah,
go
and
to
I'll link all of this. I have all this. I'll link it all in the show notes for anyone. So does that mean that somebody who lives in a different part of the country can do visits with you guys virtually, or they still have to be in your
has to
state?
be, they have to, I think they have to physically be in the state of North Carolina.
Okay. Okay.
They have to like yeah, be in a
But
car.
that website, tell the listeners that website one more time where they could find providers.
North American Menopause Society. And then also
Okay.
if you look at, so International Society for the Study of Women's Sexual Health is where you can find providers who are really dedicated to sexual medicine. So if you go to itswitch.org, I think I'm listed on there as well as a
Great.
provider, but you can find providers who do sexual medicine in your state.
Perfect. I'm going to link to those in the show notes as well.
And I should totally say our podcast. So we have 2 episodes out on our podcast.
Oh, this is perfect. No, this is what I was like. I want you to get this information out. So I was hoping you would say you're doing something like that. What's the podcast?
Very big. So it's called Sex in Queen City. So
Sex in Queen City.
in Queen City. Charlotte is I'm new to Charlotte, but I think the nickname or the name for Charlotte is Queen City
Cool.
So my collaborating physician, Dr. Sasha Davenport, is amazing. She's the director of the practice here where I work, and she and I are doing a podcast together called Sex in Queen City.
Yay. That's
Hey.
amazing. I love it. Very cool. Well, thank you, Rachel, for coming on to the pod today. It was really a pleasure. And I learned so much. And I think we need to just keep these conversations going because they're really important.
I love it. This is so much fun. Thank you so much for having me.